Welcome to Bodies, Borders, and Breakthroughs, your podcast for a deep dive into the minds shaping global health professions education. In this episode, we will be exploring the work of Dr. Jesse Bump, whose research brings a historical and political economy lens to some of the most pressing challenges in global health and medical education today. Drawing on history, social science, and policy analysis, Dr. Bump's research spans local and global scales, offering insights into how societies understand and manage threats to public health. Welcome, Jesse. It's wonderful to have you here. I'd like you to start by telling us a little bit about yourself in your world of history and global health research.
Well, thank you. It's great to be here. I'm delighted, and thanks for asking. Look, the probably the place to start with any researcher is like who they are. And I grew up on a cattle farm in the U.S. state of Vermont, um, a remote setting, uh, low resource, as you'd say. And I wondered about the world around us. We didn't have neighbors that you could see. We had cattle, but and nature all around us. But I was curious. I just wanted to know about the rest of the world, and so I read a lot and traveled that way. We didn't have money to actually go anywhere most of the time, but I found that by reading, I could explore the rest of the world, and it seemed like both a fascinating place and an unfair and unequal one. And I was always drawn to those stories that had emancipation, oppression, struggles about rights, um, the endless quest, or thus far endless quest to advance equality. I was just attracted to those things. Fairness mattered a lot to me. And
Mhm.
so the way I began to understand the rest of the world was from that lens. And it's just sort of personal, but it made sense to me that that would be a historical question. It was like, how did we get here sort of logic. And so when I had the chance to specialize more, I did. I studied in college. I majored in astronomy and history. I liked
Mhm.
science and I liked history, so I did both of them. And then I ended up getting a PhD in the history of science, medicine, and technology, in
Mhm.
part because I was still asking these same questions of like, how did we get here? And for me, it was always a curiosity that had an applied edge. I wanted to explain what was around us, but I also wanted to do something about it. And I thought by understanding the historical perspective, it would illuminate both what was right, what was fair, what was just, and
Mhm.
in cases where that didn't prevail, like what you could do about it. Now, it
Mhm.
helps you imagine a different world, one that we don't have. Like, what would be fair in this case? Or what would be
Mhm.
a starting point for thinking about what would be fair? And that was how I came toward global health out of history. I I realized that as a profession, historians aren't universally concerned with the policy aspects or the implications, and professionally don't have very many tools for generating inference. That is,
Mhm.
in political science or in social sciences more generally, you're asking questions, building models, and thinking about predictive or causal questions so that you could do something, change something, manipulate something, influence something. And I wanted to do that. I wanted to be able to take historical information, examples, data, and put it into a different set of frameworks that would
Mhm.
allow you actionable insights. So global health seemed like the probably the most the safest area. I thought about it as a safety thing. I thought like if you're going to make decisions that influence others, so without their participation, um, then how would you measure trade-offs, right? Would you ever be able to say that fish are more or less important than electricity? And I
Mhm.
thought like those are internal questions. Like a society has to answer that for itself. But
Mhm.
as an outsider, it seemed safer to me to presume that people wanted to be healthy, that they
Mhm.
wanted to avoid diseases, they wanted well-being, and that if I were ever going to uh, in act without democratic processes. Most of the world is set up that way. So even if you want something that's inclusive and participatory, the inequalities that define us, that define our world and shape all of us in it, they often prevent that. So I thought
Mm,
of these terms like, well, if I'm going to make presumptions about what other people want, I want to start with this one, that they want to be healthy. And so I thought that by focusing on those areas about humanitarian issues and especially health issues, I thought that was a safer place to make a presumption than anywhere else. And that health also seemed like one of the most basic elements of fairness and one of the most basic, um, I guess, most basic underpinnings of equality. So I
mm,
came to health that way. And since I was already trained in history and I was understanding it, understanding unfairness from a historical perspective, it made sense to emphasize those insights when it
mm,
came to the practice of global health.
mm. So it's I'm always fascinated by how people find themselves where they are, and you've given us a nice, a very rich and interesting narrative. It reminds me of one of our other guests who also talked about being on a farm and remotely, and then had the same kind of ideas of bringing the world to them through reading. So I feel compelled now, drawn by my own interest, to ask you if you remember what kind of particular books brought you from a farm in Vermont to that brought the world into your mind and to your life. What kinds of books?
Well, there are lots of kinds, and near where I grew up was where Rudyard Kipling, the British author, is where he had written the Jungle Book. This sounds kind of strange because it's about India, and he's probably the leading literary figure of colonialism. But he wrote
Mm,
the Jungle Book in Vermont, and I didn't realize that at the time, but we had a copy, and I read it, and stories about other parts of the world, to me, they were just filled with wonder. And some of them were fanciful, like his Just So stories, which is
mhm,
how the elephant got its trunk, which is like
mhm.
crocodile pulls on it, and
Yes,
these
yes,
are things that I didn't take seriously as statements of reality, but they were experiences of wonder. There's different worlds out there with different animals and different people and different ideas. So
yeah,
as a very young person, uh, I was exposed to lots of ideas just by children's stories. Some of them were, later I realized how biased some of them were or how damaging some of them were. But as a little kid, I just liked learning about things that were different. It's the
yeah.
imagination that any kid would have. Like, imagine an animal that's so different from ones that you would see around you.
All right.
Imagine a world where the animals talk to each other and they talk to you and you can have friends. And Romulus and Remus, the founders of Rome, were
Yeah,
raised by wolves. We read those stories too. uh,
yeah.
Greek mythology often has animals that participate. So these ideas, somewhere between mythology, various kinds of religion, fanciful depiction, kid stories, those were among the very earliest. And as I got older, I read things like Man-Child in the Promised Land by Claude Brown. He's
Mm,
he was an author writing about Harlem, about New York City in the 60s, and
mm,
writing about Black experiences. And I'd
mm,
never been to a city, never lived there, and
mm,
it really changed my world to think about
mm,
how this could be an experience in the same country that I occupied. That where he was talking about
mm.
drugs, oppression,
Yeah.
violence in the neighborhood, finding beauty in oppression, and just the ordinary portrait of life, some beautiful, some ugly, but so different. Like I couldn't imagine it for myself, so I read it from him, and it started to change my sense of urgency
Mm,
about what needed to change. I thought it was
Mm,
unfair. I was like,
mm,
why, as a little boy, would he have people doing heroin around him?
mm,
Or why would he live um, in apartments that were dominated by different groups?
mm,
So what I mean is, his family lived in an area controlled by slumlords, so they had unfair
mm,
living conditions,
mm,
high rent, low services. I thought, well, this doesn't sound like the U.S.
mm,
that I had learned about in school.
mm,
Where we think of the Declaration of Independence, where
mm,
all people are created equal,
mm,
and fairness is a central underpinning of the country and its identity. No, even so, I mean, even though clearly the interaction between the United States and the colonists and the Native Americans, that did not end in a fair way. And it didn't
mm,
proceed in ways that observed laws or rules that we would think are central, right? The genocide of Native peoples is, and then slavery after that. Clearly there's many areas where the U.S. has not lived according to its principles, but that's not a statement about whether the principles matter or not, or whether they are good or could be believed. So I believed them. I believed in fairness and equality and freedoms of expression, freedoms of assembly, a free press. And here are people writing from Harlem as part of the Black Power movement,
mm,
where clearly they don't have those same privileges. That was the biggest puzzle for me. It was like, how
mm.
could this be?
Yeah,
And why would it not be fixed or rectified?
right.
This was very naive on my part, but I sort of thought, well, as soon as you find an injustice, then it would be rectified.
Mm, yeah.
Everyone would stop and say, oh, well, this isn't fair. And
Mm,
that's sort of the way things worked in Vermont. Um, Not completely, but there's a really strong community sense
mm,
of what's right and wrong, and people help each other out. The
right.
institutions don't get involved in many cases.
Mm-hmm,
So you hear your neighbor is sick and you bring them some food. Or
mm,
if they're having a hard time, maybe you bring them some firewood.
right.
It's like survival itself uh, is a major concern.
Mm,
So somebody who's disabled or weakened, maybe they're sick, could be anything. Maybe you go over and help them shovel out their car in the wintertime.
mm,
Or if they can't drive, there's an economy of these mutual assistances that neighbors give each other. And there's so much labor that, you split firewood, you carry things. Uh,
mm,
Farming is really about taking something in one place and putting it in another. If it's big,
mm,
you split it up. If it's small, maybe you bundle it together. There's a lot of those process things, and they're the same amount of work for everybody. So there's a natural sense where inequality is limited just because everyone has the same things to do.
and there's cooperation.
Yeah, yeah. So in that world where if you saw somebody disadvantaged in some way, you'd help them out.
Yeah, because you might have the same experience not too
Yeah,
long in the
I
future.
mean, it's just part of the community.
Yeah.
It's a very sort of it's a mixture of Puritan and Pilgrim, very
Mm,
Anglo-Saxon attitudes where
mm,
responsibility is one of the most central parts of life.
mm,
Independence, personal accountability.
mm,
Those
mm,
things all really matter.
mm,
And the respect and dignity that it takes to live that way is quite common. So people look
mm.
out for each other in this sort of standoffish way.
Yeah, individualized keyboards. I mean, I think that that metaphor that you used is very enlightening. I understand it immediately and can relate. So, a final question before we take our leave of each other, which is it, and I'm going to come back right back to medicine and perhaps more specifically to medical education. What are the kind of questions that you would like to see people not answering, but engaging with when it comes to medical education, reflecting on your experience as a historian, especially within imperialist and colonial and anti-colonial frames. Where would you like to see medical education unpacking and investigating their own history? I know it's a big question. What
Sure,
springs to mind?
there are a bunch of good answers. I think they're good answers anyway. One of them is that medicine is predicated on an inequality of knowledge. That is, if the physician or whatever the clinician may be, but let's say physician for the moment, if the physician has exactly the same knowledge as the patient, then the patient doesn't really need the physician. I mean, except maybe to scratch their back or something that they can't do physically. But ideally, from the patient's perspective, the inequality of knowledge would be maximized because you want a clinician to know as much more as possible.
Mhm,
Right? So whatever you know, like you want a clinician who knows a lot more. So what you're aiming for in this inequality of knowledge would be the most knowledge about you or your condition or your health, whatever it may be. And that inequality, which is also it tends to be mirrored in inequalities of institutional power, of resources, of money, many different areas. But that inequality of knowledge is part of what we try to bridge with the doctor-patient relationship. And
mhm,
particularly around questions of informed consent, we're trying to reduce that. And fundamentally, it can't be reduced. All these things come down to, do you trust your physician? Do you trust this clinician? And if you could understand it perfectly, you probably don't need them.
mm,
Right? So you actually want something that you don't understand because you want them to understand more.
mm,
Right? So you have this system that is based on an inequality that you're also trying to constrain. And in areas of high trust, this is not a problem because uh, the patient and the physician will align around principles. They will agree on regulatory issues, safety issues, and the patient can safely trust the clinician's judgment.
mm.
In global health, we're operating outside that framework
Yeah.
where people are making decisions at great distance, both intellectually, personally, physically,
Mm, mm,
from the people who are affected. So, one thing I would want medical students to think about is when they're forced to bridge this gap, how do they do so fairly? How do they do
mm,
so ethically, safely?
mm,
What
mm.
principles are going to guide them when they know they need to prioritize the patient's interest, but they have no idea what those interests are?
Dr. Jesse Bob, it was such a pleasure to have you talk to me today. And as always, when I speak to you, my mind goes to places where I never imagined I would be. And so I'm very grateful that I could share one of my conversations with hopefully what will be many, many people. And thank you so much for your time.
Oh, you're very
Um,
welcome. Thank you. It's been
okay.
my pleasure.